Okay, I'll ask our guests to please take their seats, and subcommittee will come to order. Chair will recognize himself for an opening statement. Today's hearing will examine 5 bipartisan legislative bills designed to make common sense improvements to the Medicare and Medicaid programs. First, the committee is happy to have with us one of our own colleagues, Representative Lynn Jenkins from Kansas. Representative Jenkins will be testifying on our first panel about a bill she is sponsoring, H.R. 2878. This bill would simply prohibit Medicare contractors from enforcing supervision requirements for outpatient therapeutic services in critical access and small rural hospitals for another year. The Senate companion to this bill was approved by the Senate Finance Committee in June, so we're pleased to be able to review this bill today. On our second panel, we will hear from representatives of the Government Accountability Office, GAO, and the Medicaid and CHIP Payment and Access Commission, MACPAC. GAO and MACPAC will help us in our review of 4 bipartisan bills to improve Medicaid. The first Medicaid bill is an updated version of H.R. 1362, the Medicaid Reports Act by Vice Chairman Guthrie. This bill seeks to address GAO and MACPAC findings that the Centers for Medicare and Medicaid Services, CMS, does not collect accurate and complete data from all states on the various sources of funds to finance the non-federal share. This bill requires states to submit a report at least once a year on sources of funds used to finance the non-federal share of expenditures in the Medicaid program. This issue is important policy because state financing approaches affect Medicaid payment methodologies and payment amounts, which may affect enrollees' access to services. The next Medicaid bill is H.R. 2151, sponsored by our colleague, Representative Chris Collins. The Improving Oversight and Accountability in Medicaid Non-Dish Supplemental Payments Act would improve the calculation, oversight, and accountability of non-dish supplemental payments under the Medicaid program. This is important because GAO found gaps in federal oversight of high-risk supplemental payments, including a lack of information on the providers receiving them, inaccurate payment calculation method, and a lack of assurances the payments were used for Medicaid purposes. In 2014, MACPAC recommended that the HHS collect and make publicly available provider label non-dish supplemental payment data in a standard format that enables analysis. Thirdly, the updated version of H.R. 1361, Medicaid Home Improvement Act, sponsored by Representative Guthrie, would establish a federal cap on the home equity allowance consistent with the current federal default of $552,000. This bill would preserve existing beneficiary protections, but help protect taxpayers by updating the limit of allowable equity interest a beneficiary can have in their home. This is a common sense step to prevent cost shifting from the private to the public sector. And finally, the Quality Care for Moms and Babies Act, sponsored by Representatives Engel and Stivers, seeks to improve the quality, health outcomes, and value of maternity care under the Medicaid and CHIP programs by developing maternity care quality measures. This bill would authorize the appropriations of $16 million for HHS to identify and publish quality measures for maternal and infant health. Together, these 5 bills continue the commitment this Congress has to strengthen the Medicare and Medicaid programs to help sustain these important safety net programs for those most relying on them. I want to thank all of our witnesses for agreeing to testify today, and I yield back and now recognize the ranking member of the subcommittee, Mr. Green, 5 minutes for his opening statement.
Thank you, Mr. Chairman, and welcome our colleague from Kansas. Thank you for being here today. We're here to examine 5 legislative proposals. One impacts the Medicare Part B program, and the others affect the Medicaid program. As we know, Medicaid program has served as a critical safety net for the American public since its creation in 1965, 50 years ago this year. Today, over 70 million low-income Americans rely on Medicaid for comprehensive, affordable health care. Medicaid covers more than 1 in 3 children, pays for nearly half of all births, and accounts for more than 40% of the nation's total cost for long-term care. 1 in 7 Medicare beneficiaries is also a Medicaid beneficiary, a dual eligible. The Quality Care for Moms and Babies Act, a discussion draft put forth by Representatives Engel and Stivers, will improve health outcomes for women and children who depend on Medicaid. This legislation will authorize funding for HHS to develop quality measures for maternal and infant health and award grants related to care quality, and I support this important legislation. I'm concerned about the other legislation we're considering, such as Medicaid Reports Act and proposals requiring additional auditing on states that are overly burdensome prescriptions and likely intended to chip away at the Medicaid program. Additional transparency on Medicaid payments is a goal we all share. My priorities is always including ensuring Medicaid beneficiaries have access to the care that they need by supporting providers that serve beneficiaries who will otherwise have nowhere else to go for the necessary care. However, these bills are structured will not achieve our goal of fully understanding of Medicaid payments and whether these payments are adequate to guarantee equal access for beneficiaries within the Medicaid program. My state of Texas used supplemental and Medicaid DISH payments in a unique way. These sources of funding are an incredible important revenue stream for hospitals and providers that serve a large portion of Medicaid beneficiaries and the uninsured. For example, in Texas, supplemental payments are used for DSRIP, and I want to make sure we maintain the flexibility so CMS and states can deliver each Medicaid program the best way for its unique patient base. Providers in Medicaid program must be paid a fair rate given the complexities and in the 56 distinct Medicaid programs. There is a nuanced way to address these issues. The question you need to ask is full payment that a provider receives for treating a Medicaid enrollee fair and sufficient to ensure equal access. Unfortunately, legislation like Medicaid Reports Act, H.R. 2125, won't get us the information we need to see the full picture, and it may actually put more burdens on the states. They're not in line with actions CMS has taken to improve in the area, and I look forward to learning more about this complex issue. Reforms done for the right reasons and nuanced and intelligent way can truly improve how CMS ensures that payments to Medicaid providers are sufficient and enforce equal access to Medicaid beneficiaries. Such proposals should be a priority for our committee, and I look forward to a comprehensive discussion on ways we can improve transparency, strengthen coverage, and expand access to providers and increase the quality of health care. And, Mr. Chairman, I'll yield the remainder of my time to my colleague from Iowa, Dave Losack.
I thank Mr. Green for yielding. I also want to thank my colleague, Congresswoman Jenkins, for testifying here today on our bill. I'm happy to be the lead Democratic co-sponsor, H.R. 2878. It has been a pleasure to work with her on this issue. As a native Kansan, she truly understands the needs of rural Americans, and I thank her for her bipartisan work on the bill. Basically, what 2878 would do is suspend the physician direct supervision requirement for outpatient therapeutic services furnished at critical access hospitals and small rural hospitals until January of 2016. I often visit critical access hospitals in my district. There are many, given that I represent rural Iowa, and the number one concern I've heard about recently was this direct supervision issue. In 2009, CMS issued a rule that mandated direct supervision for all outpatient therapeutic services at these hospitals. In response to concerns over the implementation of this policy, they delayed the enforcement through 2013, which was extended by Congress to 2014. Direct supervision requires that a physician is immediately available when the service is provided. This is difficult in many of these rural settings. Many outpatient services, such as continued chemotherapy, administration of IV fluids, or drawing of blood, can be safely administered under general supervision, a fact that CMS itself recognized in its delay of the policy. Further, small rural hospitals often face staffing and workforce shortages that make direct supervision of these services incredibly difficult. There are a lot of challenges facing our rural hospitals, as you know all too well. Congresswoman Jenkins. This legislation, I think, would go some distance to remedying at least one of those issues facing them, and I thank you for introducing this legislation. I'm happy to be a part of it, and I yield back. Thank you.
Chair thanks the gentleman and now recognizes the Vice Chair of the Subcommittee, Mr. Guthrie. 5 minutes for opening statement.
Thank you, Mr. Chairman, and I appreciate my classmate from the 2008 class coming in, being here with us this morning, Ms. Jenkins. But thank you, and I appreciate you holding this hearing on a number of important bills. Today, the committee is examining two bills that I introduced, H.R. 1361, the Medicaid Home Improvement Act, and H.R. 1362, the Medicaid Reports Act. These are both good government bills that help strengthen the Medicaid program and protect valuable taxpayer dollars. H.R. 1361, the Medicaid Home Improvement Act, caps the maximum allowable equity for beneficiaries to qualify for long-term care under Medicaid. Currently, in some states, those with home equities, not home values, but home equities, of up to $828,000 can qualify for Medicaid assistance. My bill reindexes the maximum threshold to $500,000, adjusted for inflation. With an average home sale price in the United States at $221,000, the current limits allow those not truly in need to access Medicaid dollars, draining federal and state dollars. H.R. 1362, the Medicaid Reports Act, requires states to submit an annual report that identifies the sources and amounts of funds used by the state to finance the non-federal share of Medicaid. With the growing burden the Medicaid program is placing on the federal budget and those of each of our states, it is important that we know how states are coming up with the dollars necessary to meet their Medicaid match. Again, Mr. Chairman, I appreciate you holding this hearing to examine these and other important issues, and I look forward to talking more with our witnesses and yield back the balance of my time. Anybody seeking time? I yield back.
Chair thanks the gentleman. As usual, all written opening statements of the committee will be made part of the record. And we'll proceed to our first panel. On our first panel today, we have the Honorable Lynn Jenkins, 2nd District of Kansas. And we thank you for coming to talk about your legislation. You may proceed.
Chairman Pitts, Ranking Member Green, honorable members of the committee, thank you for holding this hearing and inviting me to speak on H.R. 2878, a critical piece of legislation. The bill would delay Medicare's physician direct supervision requirement for outpatient therapeutic services in critical access and small rural hospitals until 2016. In January of 2014, the Centers for Medicaid and Medicare Services began enforcing a requirement that physicians must supervise outpatient therapy at critical access hospitals and other small rural hospitals. CMS's decision meant that routine outpatient procedures such as drawing blood or undergoing active therapy would have to be directly supervised by a physician. This decision by CMS would have put a severe strain on providers, particularly those in rural areas, while providing no quality improvements for the patients they serve. Most of these outpatient procedures are relatively simple, are very safe, and would not benefit from a federal mandate that a physician always be in the room. And as a practical matter, in rural hospitals across Kansas, such a requirement is simply not feasible. I was proud to introduce legislation last Congress that delayed this Medicare direct supervision requirement through 2014. And it was signed into law with bipartisan support. It's been widely recognized as an effective tool to improve care in rural hospitals and keep the regulatory burden in check. Unfortunately, rural hospitals are once again staring down the threat of this federal mandate from CMS. The existing law delayed enforcement action from CMS has expired. Accordingly, I've now introduced similar legislation this Congress, further delaying enforcement until 2016. It is about this legislation, H.R. 2878, which this committee has graciously invited me to speak today. When I think about the healthcare needs facing my district, there's nothing more challenging than ensuring access to quality and accessible rural health care. Rural America is struggling, and the 84 critical access hospitals in Kansas are the lifeblood of our rural communities. The presence of a facility such as a critical access hospital in a community could be the deciding factor in whether or not the next generations of children decide to raise their family in their hometown, or perhaps whether or not a business decides to locate there. Easy access to emergency care can be a life and death situation, and we cannot threaten the existence of these facilities by piling on the regulatory burden from Washington. Earlier this year, I invited the CEO of Holton Community Hospital to testify about this issue before the Ways and Means Committee Subcommittee on Health. Holton Community Hospital happens to be responsible for serving my hometown, Holton, a community of just over 3,000 Kansans. She explained in great detail that direct supervision would be extremely burdensome, costly, and is simply unrealistic at a hospital serving rural America. The result of enforcing this mandate would be to severely limit the type of services rural health care hospitals could offer, and it would threaten their financial stability at a complicated and uncertain time in our nation's healthcare system. H.R. 2878 will correct this problem. It will do so by reinstating the moratorium on enforcement of this unnecessary regulation. Its broad bipartisan support in Congress and the support of key stakeholders, including the American Hospital Association, the National Rural Health Association, and the Kansas Hospital Association. As a small-town girl, I feel strongly that folks in rural communities deserve access to quality health care. I can't emphasize enough that rural hospitals, our rural communities in Kansas and across the country depend on access hospitals, like critical access hospitals, which are directly threatened by CMS's action. I hope that members from both parties can come together once again to ensure high-quality, timely care is available to you no matter where you live in America. Companion legislation was introduced by Senators Thune, Moran, and John Tester. It's passed the Senate back in September. I also want to thank my lead co-sponsor on the legislation, Congressman Dave Loebsack, and for all his hard work and advocacy on the issue as well. I urge my colleagues to support the legislation and move it forward in a timely fashion. Thank you all for allowing me to join you today.
Chair, thanks to gentlelady. Really appreciate you taking time out of your busy schedule to come and present testimony to us today. As usual, we will not have any questions for our members presenting testimony, so we'll excuse the gentlelady with our thanks and call our second panel to the witness table. And while they're setting up the table, I would like to submit the following document for UC request for the record. It's a statement from the American College of Obstetricians and Gynecologists. Without objection, so ordered. I'll introduce our second panel in the order they'll testify. First, Mrs. Catherine Iritani, Director of the Healthcare of Government Accountability Office, and then Ms. Ann Schwartz, PhD, Executive Director, Medicaid and CHIP Payment and Access Commission. Thank you very much for coming today. Your written testimony will be made a part of the record. You'll each be given 5 minutes to summarize your testimony. So with that, Ms. Iritani, you're recognized for 5 minutes.
Chairman Pitts, Ranking Member Green, and members of the subcommittee. Thank you for this opportunity to be here today as you consider ways to strengthen the jointly financed federal and state Medicaid program, now the largest health care program in the nation by enrollment. My testimony today will cover a body of GAO work from recent years on 2 complex topics: federal oversight of certain large payments states often make, known as supplemental payments, and how states finance the non-federal share of their programs. Supplemental payments are above and beyond regular payment rates for services, and states have considerable flexibility for making them. States can distribute them to only a small number of providers, often hospitals. Congress and CMS have taken important steps to enhance Medicaid program integrity through better oversight of these payments. We believe there are opportunities for even more improvements. Our recent work on certain Medicaid supplemental payments that states often make has shown that better federal information is needed to understand and oversee them. The payments have been growing in size and now total over $20 billion a year and can amount to tens or hundreds of millions a year to a single provider. CMS and others need better information to understand who states are paying, how much they are paying, and how such payments relate to services provided to Medicaid beneficiaries. Many states have made supplemental payments that greatly exceed the provider's cost of providing Medicaid care. In 2012, we found that 39 states had made supplemental payments to over 500 hospitals that resulted in total Medicaid payments exceeding the hospital's cost of providing Medicaid care by $2.7 billion. Payments are not limited to costs under Medicaid, but payments that greatly exceed costs may not be economical and efficient as required by law. Now let me turn to our work on state financing, which has concluded that better information on state sources of funds to finance Medicaid is also needed. States are allowed within certain limits to seek funds from providers and local governments to fund Medicaid payments. States can, for example, tax providers or seek intergovernmental fund transfers from local governments to help finance the non-federal share. We have found that states are increasingly depending on local governments and providers for financing, which can ultimately shift Medicaid costs not only to providers and local governments, but to the federal government. On the basis of our national survey of state Medicaid programs, in 2012, about $46 billion or 26% of the non-federal share of Medicaid was financed with funds from providers and local governments, a 21% increase from 2008. Taxes on healthcare providers almost doubled in size during that time, from $9.7 to $18.7 billion. Such taxes are subject to certain restrictions, for example, to ensure that taxes are broad-based and uniform. Cost shifts to the federal government can occur through financing arrangements that concentrate financing of the payments on those providers who receive the payments. For example, a state can increase payments for Medicaid providers, such as hospitals, impose a tax on those providers for the non-federal share, and draw down federal matching funds for the payments. CMS and other stakeholders are not well positioned to assess payments states make to individual institutional providers. Federal data on certain supplemental payments states often make is not complete, reliable, uniform, or accessible. CMS has important initiatives underway, but CMS has reported that legislation is needed to compel states to report such payments uniformly and to subject them to audit. CMS also lacks good data on state financing sources. Such data are needed to ensure financing is appropriate and to understand how payments affect beneficiary access to care. In conclusion, a needed step towards strengthening the Medicaid program is to make payments and financing more transparent. For this large and growing program, CMS and others need to know who states are paying and in what amounts, and right now CMS lacks sufficient data to know this. We have suggested that Congress consider requiring CMS to require states to report and audit these payments. We have also recommended that CMS develop a strategy for improving information on state sources of funds for Medicaid. In view of growing costs and enrollment, such transparency can help ensure the program is efficiently and effectively meeting the promise of providing medical assistance to our nation's low-income populations. Mr. Chairman, this concludes my testimony. I'm happy to answer any questions.
Chair thanks the gentlelady, and now recognizes Ms. Schwartz, 5 minutes for her opening statement.
Good morning, Chairman Pitts, Ranking Member Green, and members of the Subcommittee on Health. I'm Ann Schwartz, Executive Director of MACPAC, the Medicaid and CHIP Payment and Access Commission. As you know, MACPAC is a congressional advisory body charged with analyzing and reviewing Medicaid and CHIP policies and making recommendations to Congress, the Secretary of HHS, and the states on issues affecting these programs. Its members, led by Chair Diane Rowland and Vice Chair Marcia Gold, are appointed by GAO. And the insights I will share this morning reflect the consensus views of the Commission itself, anchored in a body of analytic work conducted over the past 5 years. And we appreciate the opportunity to share our views this morning. My comments today will focus on reporting of provider-level data on non-DISH supplemental payments and contributions to the non-federal share, the subject of 2 bills being considered by the subcommittee, H.R. 2151 and H.R. 1362. The Commission shares the objective of transparency reflected in these 2 bills. There are several compelling reasons that provider-specific data should be reported. First, these data are necessary for assessing whether state payment methods and rates are consistent with federal statute. While states have considerable flexibility in setting rates and payment methods, Section 1902A30A of the Social Security Act requires that Medicaid payments be consistent with efficiency, economy, quality, and access, and that they safeguard against unnecessary utilization. But information on the base Medicaid payments that providers receive, that is the per case or per diem payment associated with the delivery of specific services to specific Medicaid beneficiaries, provides only a partial picture of how much Medicaid is paying a given provider. To assess payment fully, policymakers need to know the amount of Medicaid payment that providers receive, including both claims-based and supplemental payments, less the amount that providers contribute towards the non-federal share of Medicaid expenditures. The level of payment can be considered the most basic measure of economy and is essential to an assessment of patient efficiency, a measure of value that compares what is being spent, economy, to what is obtained, quality, access, use of specific services. Typically, an analysis of whether a healthcare payment is economical includes comparison to the cost to provide a given service and a comparison to what other payers pay for a comparable service in a given geographic area. Other healthcare payers, including Medicare, commonly conduct such assessments. In Medicaid, however, federal policymakers and program administrators do not have complete data to make such assessments, and therefore to ensure that payments are consistent with the delivery of quality necessary care to beneficiaries. The second reason for collecting provider-level data is that Medicaid spending for supplemental payments is substantial and growing. In fiscal year 2014, states reported making $24.2 billion in non-dish supplemental payments to hospitals, more than 20% of total Medicaid fee-for-service payments to hospitals nationally, and more than 50% in some states. The amount of funds raised through providers and local government contributions is also significant and increasing. As such, the federal government has a reasonable expectation of having complete payment and financing data that permit it to understand and oversee states' use of Medicaid funds. In light of these concerns, in March 2014, MACPAC recommended that the Secretary of HHS collect and report data on non-dish supplemental payments at the provider level. And just last week, in deliberations on a report on disproportionate share hospital payments that is due to Congress on February 1st, the Commission voted unanimously on a recommendation focused on reporting of data for both payments and the non-federal share. Specifically, MACPAC recommends that the Secretary collect and report hospital-specific data on all types of Medicaid payments for all hospitals that receive them. In addition, the Commission recommends that the Secretary collect and report data on the sources of non-federal share necessary to determine net Medicaid payment at the provider level. Efforts to fully understand provider payment levels are more relevant now than at any time in the program's history. Use of supplemental payments is growing, particularly to hospitals through Section 1115 Expenditure Authority. In addition, interest in payment reforms that incentivize greater value in the delivery of health services is also growing. Even so, lack of solid data on net payments makes it extremely difficult to assess the effectiveness of these efforts. MACPAC shares this subcommittee's interest in ensuring that taxpayer dollars are spent appropriately on delivering quality necessary care and preventing and reducing fraud, waste, and abuse. Provider-level data on supplemental payments and contributions to the non-federal share would provide greater transparency and facilitate Medicaid payment analysis, including assessments of Medicaid payment adequacy and analysis of the relationship between payment and desired program objectives. Again, thank you for this opportunity to share MACPAC's work with the subcommittee, and I'm happy to answer any questions.
Chair, thanks the gentlelady. Thank both of the witnesses for your testimony. I'll begin the questioning and recognize myself 5 minutes for that purpose. This is for both of you. We'll start with you, Ms. Iritani. What data does CMS currently collect about the sources of the non-federal share of Medicaid funding?
CMS collects some data on the sources of funds on a case-by-case basis. When states submit a new request for approval for a state plan, CMS asks several questions about the sources of funds. It's not very accessible, this data. and it's not in a uniform manner. CMS also collects some data on provider taxes, but CMS acknowledges that the data are unreliable and incomplete.
Anything to add, Ms. Schwartz? Let me ask you, what additional data do you think they need? And how will having this data improve CMS's ability to oversee states' financing of Medicaid? Both of you.
Additional data that CMS needs includes data on all sources of funds used to finance the Medicaid program. Currently, CMS does not collect this data. In order to understand net payments to providers, as Ms. Schwartz has discussed, the need for understanding, we need to understand whether or not the financing of payments is being concentrated on certain providers that also receive payments. And in order to understand this, we need to collect complete data on how states finance the non-federal share of payments.
Ms. Schwartz, want to add anything?
Just to add that our primary concern in conducting this analysis is to get provider-specific data on their contributions to the non-federal share, which would allow us then to net those contributions out from the total payments that they're receiving Medicaid to get a true picture of what they are being paid.
Okay. Now, Ms. Aratani, in your written testimony, you indicate that HHS acknowledged that additional data was needed to ensure that states comply with federal requirements regarding how much local governments may contribute to non-federal share. But despite this, HHS has said that no further action is needed. Can you explain these seemingly contradictory statements? Explain why GAO believes that additional data is necessary to properly oversee the program?
Yes, we made a recommendation to CMS that they develop a strategy for collecting better information. And I think CMS disagreed because they did not believe that information on the sources of Medicaid financing was needed on a payment-specific basis. They collect information in the aggregate, but they don't collect information that would enable us to ascertain how much individual providers are collecting, as Ms. Schwartz discussed the need for.
Now, what does the required reporting and auditing of DISH payments tell us about the utility of requiring similar reporting and auditing for non-DISH supplemental payments?
The DISH payments are subject to complete reporting of both the financing of the payments and the information for non-DISH payments is lacking. And I'm sorry, could you repeat the question?
Yeah. What does the required reporting and auditing of DISH payments tell us about the utility of requiring similar reporting and auditing for non-DISH supplemental payments?
Right. So the required reporting and auditing of DISH payments has been very important for understanding who the payments are going to and at what levels. And the non-DISH payments are currently not subject to similar requirements.
Okay.
We have suggested that non-DISH payments really need to be comparable to the DISH payments in terms of the extent of the reporting. Currently, one cannot tell with the non-DISH payments the net payments that providers are actually receiving, because you cannot tell on a provider-specific basis what a provider is actually contributing to the financing of a particular payment. So the financing of a payment could be, for example, 100% concentrated on on the providers who receive the payments. Therefore, the net payments that the providers receive is actually much lower.
My time's expired. Chair recognizes the ranking member of the subcommittee, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. And I'd like to ask the panel provide information on how Medicaid payments work. I think Medicaid payments are so complicated. Even as I was a state legislator in Texas, it was tough. I know that we appreciate a little more information about how this actually works. Ms. Schwartz, given that the issue of rate setting is so complicated, can you explain how states set these rates and what types of payments are provided to providers and what's reported to CMS?
Yes. Setting payment rates and methodologies is one of the parts of the Medicaid program that varies the most. Hospitals pay hospitals in very different ways. Some of them use a system similar to the prospective payment system in Medicare, where they make a per-case payment at the diagnosis level for a number of different services that are provided in the hospital. Some states still pay hospitals per diem. The range is all over the place in both how they pay, the special adjusters they have for that, and the actual payment rates. We have collected some of this information from MACPAC, and it's a rather unwieldy spreadsheet that gives you a sense of the complexity of those payments. One of the things that MACPAC is most interested in is trying to get a sense of how payments can be used to leverage proper, appropriate, greater value care. And as part of that, we need to be able to know both the methods and the payment rates and to be able to net out these additional payments. So it's quite complex with considerable state flexibility reflecting the historical practices and their local markets.
Okay. Mr. Hirotani, my understanding is it's very hard to gather Medicaid data and indeed to compare Medicaid data given the time lag on availability of that data and how different all these programs are from one another. Is that a problem you encounter regularly in your work at the GAO?
Regular payment data is available to us, but the supplemental payments that states often make are not reported in the claims data that go to the CMS. So states really have all the data that shows who those payments are going to. And so that's part of the transparency that we believe is needed is more data at the federal level on who supplemental payments are going to and for what purposes and in what amounts.
Ms. Schwartz, I thought your point about linking other sources of data to better understand a full picture of the payments was interesting. Can you expand on that recommendation?
Well, as Ms. Hirotani says, claims are available and are reported up to the federal level, so we know on a per case or per diem level what hospitals are making. Supplemental payments are not paid associated with claims, and what is reported by the states to the federal level is the aggregate amount across all institutions in a particular class, and we can't associate that big chunk of dollars that is being reported to the particular institutions that receive them. States clearly know this information because they're making the payments, but states also have many different data systems and approaches to making those payments, and so you can't just go out and ask every state report this information and get the right answer. So that's the desire to have the secretary specify a method by which those data would be reported so that they could be consistently reported and available to analyze both at the national level and across states.
Okay. Both, Ms. Hirotani, both you and Ms. Schwartz mentioned that CMS is actually taking quite a number of steps on the issue, and I'm glad the administration is taking those steps in recent years to shed light on. I know this has been a GAO recommendation through administrations on both sides of the aisle. Can you talk about CMS work on non-supplemental payments in recent years? Wasn't that work based in part on long-standing GAO recommendations? And is it true that CMS hasn't even finished rolling out the new actions on the supplemental payments?
Yes, CMS has taken some significant steps. We would agree to try to improve the transparency and accountability of supplemental payments. Recently, CMS has, for example, had initiatives to try to require states to submit reports that would provide information on the financing and payments for supplemental payments. This information is more than what they've had before. It's extensive. CMS has provided that information to a contractor to assess how they can use it to improve oversight, for example. CMS also has an initiative known as TMSIS, Transform Medicaid Information System reforms to try to collect better information on claims that would include supplemental payments.
Okay. Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. I recognize the Vice Chair of the Subcommittee, Mr. Guthrie. 5 minutes for questions.
Thank you, Mr. Chairman, and my questions to Ms. Iratoni be directed at you. And I know you've talked about some of the things I'm going to ask about, but I'd like to give you a chance to elaborate as I through the question I'm going to move forward. So, in your testimony, you point out that states generally use general revenue funds for their Medicaid share, but you point out that states can use other financing options, specifically that states are increasingly relying on providers and local governments to finance their Medicaid share. Can you discuss some of the ways states are financing their Medicaid share? Besides just general revenue, just other.
Governor, what we've reported on are, apart from the general revenues, which is the majority of how states finance, is the growing reliance on taxes on healthcare providers, for example, to help finance the non-federal share of payments, intergovernmental transfers, which can be used between units of government to...
Can you give an example of one? An example?
So, for example, a local government may operate a hospital, and an intergovernmental fund transfer might be a transfer from the local government to the CMS, to the state that it's in, to provide the non-federal share of a payment that is going to the provider. And another method is known as certified public expenditures, which is basically certifying that expenditure was made for Medicaid. That can also be used as a non-federal share.
Okay. And I think every member of this committee wants to ensure that vulnerable beneficiaries are protected and receive the Medicaid benefits which they're eligible. But I know many of us also want to ensure that federal Medicaid policy doesn't unnecessarily crowd out private sector's role. Medicaid long-term care is the largest chunk of Medicaid spending and represents one of the biggest challenges to the program's sustainability over the long term. My bill, H.R. 1361, the Medicaid Home Improvement Act, seeks to address the concerns of GAO in this area and requires states to submit an annual report identifying the sources and amounts of funds used to, this is the Medicaid Report Act, I'm sorry, use funds to finance their non-federal share of Medicaid. Can you talk about how that'll be beneficial as we move forward?
Yes, currently CMS does not collect data on the sources of funds that states use for Medicaid. And there are several reasons why we believe that information is needed. One is just to enforce Medicaid requirements on limits that are set on the extent that states can rely on providers and local governments. There's a limit that states cannot, it's called the 60-40 rule, that states can only obtain a certain proportion of funds from local governments and providers. The other is just to understand net payments that providers actually receive. Without having better data on the extent that payments are being financed by the providers who receive the payments, we can't really understand net payments to providers.
Okay, also, a bill I have today is the Medicaid Home Act that changes the equity requirement to $500,000 plus plus inflation. Can you talk about if this policy were adopted, how individuals could access the equity interest in their home through a variety of legal means, such as reverse mortgages, home equity loan, or other financial vehicles?
I am not prepared to answer that question, but I'd be happy to get information for you for a
Okay.
question for the record.
All right, and can you talk about, there's an exception under current law, which my bill does not change, which allows an individual with any level of home equity to qualify for Medicaid if an individual's spouse, child under 21, or child who is considered blind or disabled also live in the home? You familiar with that provision? Was that, maybe Ms. Schwartz, you have a, shaking your head on that, do you have a?
Yes, that's correct.
That's correct, okay. And given the, there are a few seconds here, given the aging of the baby boomers and the growth in long-term care, have MACPAC or GAO conducted any analysis about the challenges unrestrained growth in this part of the program poses to federal and state budgets? For example, CBO estimates that federal spending alone on Medicaid long-term care will be $77 billion this year. So is GAO or MACPAC looking at the long-term care and the ensuing baby boomer arrival, not just at retirement, but also older in life, so that more demands on long-term care?
We have several engagements underway around long-term care and Medicaid.
Thanks.
Yes, and MACPAC is engaged in a long-term work plan on analyzing spending trends, different aspects of the Medicaid program, and we're just beginning that work, and since long-term care is such a significant part of the program, it will be included as part of that area of work.
Thank you. My time's expired. Now yield back.
Chair, thanks, gentlemen. Now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. I want to follow up on my colleague's discussion of long-term care. Dr. Schwartz, I'd like to discuss how the proposed Medicaid Home Improvement Act would affect beneficiary eligibility for long-term care services. As you know, the Medicaid program is the backbone of our country's long-term care system. Sadly, even with Medicaid as the safety net, the majority of Americans lack the options or resources to sufficiently plan for future long-term care needs. And, you know, my questions relate to obviously to the spend down provision, which I think is a terrible way to pay for long-term care, actually shameful in my opinion. The last thing I want to do is to take someone's home to pay for their long-term care. Could you briefly describe the purpose of the home equity exemption?
I think there's two purposes. One is to allow living family members to remain in the home while the beneficiary is in an institution, and the other is there's the limit that exists on there to ensure that that the government is seeing a contribution of assets to their care. So that's the purpose of the
Oh, thank you. And states are allowed the option of maintaining a higher home equity threshold. What is the purpose of allowing states to choose between different equity allowances? I know for New Jersey, you know, in our state, it's much higher. We've chosen the option of the higher equity.
Well, I'm not an expert in this area, and it's not an area where MACPAC has done any significant work. But in general, states exercise flexibility in definitions within the program to reflect local circumstances in their communities. And I do believe New York and New Jersey are two of the states that have allowed a higher exemption, presumably reflecting the higher market value of real estate in those areas.
I mean, absolutely the case. I mean, it's not unusual at all for, you know, a person of average income, you know, to be living in a home that's worth $800,000, which I think would qualify in New Jersey under the higher, because New Jersey's opted for the higher equity, but might not, but I think wouldn't qualify if this bill became law because they wouldn't allow states to have a higher threshold. Would you expect the Medicaid Home Improvement Act to have different effects in different states because it wouldn't allow this higher threshold?
Well, certainly to the extent that states have a higher threshold now would affect those states more than those who have a threshold similar to what's in the bill.
Thank you. I mean, my concern, Mr. Chairman, you know, I find this proposed piece of legislation to be very concerning with regard to this home equity threshold and not allowing states to raise the threshold. I mean, our country, we know, has still not implemented a thoughtful, comprehensive approach to long-term care, yet this bill would only serve to restrict eligibility to long-term services and supports. And I would, you know, I can't stress enough that in states, you know, like New Jersey, where, you know, real estate, you know, you have this much higher ability. It costs a lot more essentially to have a home in New Jersey, and I mean, the last thing I would want to see is people to have to, sell their home because the threshold is reduced. Let me ask you, Dr. Schwartz. I understand that Medicaid and CHIP have experience in quality performance measures through the Pediatric Quality Measures Program, and this program was established in 2009 with the goal of improving the quality of care delivered to our nation's pediatric patients. Could you briefly describe the Pediatric Quality Measures Program and the effect it's had in advancing pediatric care for Medicaid patients? You have a minute.
Sure. The core set of measures, as you mentioned, was developed in 2009, and all states are reporting at least 2 of the measures. The median is 14 measures. And they're things like the share of kids between the ages of 3 and 17 with an outpatient visit to a primary care practitioner, the share of children up to the age of 2 who are up to date on their vaccines, share of births at low birth weight. These are areas that are agreed have a clinical definition as being meaningful from the purposes of high-quality care. MACPAC has commented on the importance of improving the number of states reporting those measures and increasing the number of measures, and also strengthening the capacity of CMS to calculate those measures for states from claims data to the extent that's possible.
Do you have any suggestions for improvement? I know my time is almost up, but if you had to mention 1 or 2.
To the extent that data from claims that states submit up to CMS, that those data can be used and that require no additional data collection on the part of states, that would be a really valuable way to get more information on the performance of different states in providing quality pediatric care.
Thank you. Thank you, Mr. Chairman.
Chair thanks, gentlemen. Now I recognize the gentleman from Illinois, Mr. Shemkus, 5 minutes for questions.
Thank you, Mr. Chairman, and welcome back. It's good to see you. This question would be for both of you as I begin. Many of us are familiar with the disproportionate share hospitals or DSH supplemental payments. However, can you please explain what non-DSH supplemental payments are, who they go to, and what purpose they serve? Ms. Iritani, why don't you start?
Yes, the non-DSH payments are a type of supplemental payments that states often make under the upper payment limit that is established under Medicaid or under Medicaid demonstrations. The purposes are largely unknown, which is part of why we believe there is a need for more reporting so we can understand who these payments are going to and for what purposes.
Ms. Schwartz, you want to comment on?
Sure, I can just say the non-DSH supplemental payments are calculated by a state looking across a class of providers, say public hospitals, nonprofit hospitals, looking at the total payments under fee-for-service that are paid, and then the difference between that payment amount and what would have been paid under Medicare principles, which is generally more. So the difference there is the amount that the state can make in non-DSH supplemental payments, and it uses those funds presumably to target different types of hospitals. But again, as Ms. Iritani said, that's one of the reasons we would like to be able to get the provider-specific data to see the relationship between the specific payments and which hospitals are receiving them.
So in the question previously, Ms. Iritani, we were talking about general fund payment, and I think you did raise the issue of taxes. So some states use provider taxes to finance the non-federal share of Medicaid cost, which has been used to shift costs to the federal government. Can you kind of talk through that?
Yes. So to the extent that financing of large payments is concentrated on the same providers receiving those payments, there can be a cost shift. For example, when we looked at this issue in a recent report, we looked at certain new arrangements that states put in place where they increased provider payments But they, at the same time, imposed a tax on those providers, the same providers, to pay for the non-federal share. And so then they drew down the federal matching for that payment, for those payments. And in the end, the federal government paid much more, hundreds or tens of millions for those new payments. The providers who received the payments funded the non-federal share, and the state ended up not having to pay more for those payments.
Ms. Schwartz, do you want to comment? No, that's fine. The and last from Ms. Iritani, GEO has had long-standing recommendations for CMS to require additional reporting and auditing of non-DISH supplemental payments. Why don't you think CMS has implemented those recommendations?
CMS has agreed with our findings, and but with regard to that particular recommendation, they said that they would need to be required to do so. Because of the effect on states, that they would need legislation to be ordered and to be able to do that.
Okay, very good. I yield back my time. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now I recognize the gentlelady from Florida, Ms. Castor, 5 minutes for question.
Great, and that's right where I want to pick up. So CMS says that they do not have the authority to go out and collect all of the data from states on their supplemental payments. Do you agree with that? Do you think that legislation is needed?
We defer to CMS on that. We believe that, in the past, when CMS has tried to require states to report information that states didn't necessarily want to report or want to report at the level that CMS needed it, CMS needed legislation.
Ms. Schwartz, do you agree with that?
CMS is collecting information from states to demonstrate compliance with the upper payment limit regulations. And for the purposes that MACPAC is interested in, the payments on provider-specific data on the non-DISH supplemental payments from those regulations might be sufficient. We don't have any access to those data. CMS does not share a lot of details. We do know that they have been talking about a regulation on supplemental payments, so it does seem that there is activity going on, and that as part of its oversight activity, it does have the ability to collect the payment information. I believe an audit is another level on which I think it's probably fair to say that they would need legislation to conduct an audit as they had to do the additional.
And it certainly would give them the leverage to say to states we need it to be accessible and we need it to be uniform, because these supplemental payments go to all 50 states, correct? So oftentimes I imagine the data comes back in different forms. What impact now has Medicaid expansion in some states and not in others had on supplemental payments?
I'm not sure that we've done the analysis of the supplemental payments of expansion versus non-expansion states, and it's something that we could do. In any case, it would still be at the aggregate state level and not give you a picture of what's happening to individual providers.
How about with the expansion of the 1115 waivers and supplemental payments? Has the trend towards states having those Medicaid waivers changed the format of supplemental payments at all?
Many of those waivers have allowed states to continue making supplemental payments, and so we do know that those payments under the 1115 waivers are increasing.
So, and in the Medicare or Medicaid managed care rules that were proposed recently, did those rules propose any type of standardized reporting for supplemental payments? through the waivers or?
I'm not sure if the rule specifically mentioned that, but in general, supplemental payments are not permitted under managed care, because in managed care, the plan is making a payment to the institution, not the state.
So it's more applicable to the 115, the 1115 waivers to states than in managed care rules, for sure.
That's my understanding.
Okay. In one example, I wonder if GAO has looked at states that have taken supplemental payments and done things with them that really are outside the bounds of the intent of the Medicaid laws. Do you know of any cases where states have said, okay, we're going to use supplemental payments, that revenue, and pay providers that don't serve the Medicaid population?
Years ago, in prior reports, we have looked at how excessive supplemental payments were used by states and did find that the payment revenues could be used for non-Medicaid purposes. And in more recent years, we've just been looking at the level of the supplemental payments and how that they relate to costs of the providers for providing Medicaid, and that's where we found, that many states are making payments that are much above
in
cost.
Florida, we've had that. We had that crop up where the state went in and said, "Here, we're going to take some of these supplemental payments and give it to some providers that were not serving Medicaid population." And that's a real worry in my home county that has a 0.5-cent sales tax that they use as an intergovernmental transfer and to bring down their Medicaid match. So I think this is a very good idea for us to standardize the reporting from states and get all the data so we can ensure the funds are being spent accordingly. Thank you, and I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from Missouri, Mr. Long, 5 minutes for questions.
Thank you, Mr. Chairman. And Ms. Iritani, what factors prompted CMS to require audits and reporting of the DISH payments?
CMS identified concerns with states making excessive payments over the limits, and Congress had required them to also establish reporting and auditing requirements. And some of our work also found concerns with excessive payments and also requirements on providers to return the non-federal share to the state, so effectively reducing the net payments that some providers received. So CMS did and now requires DISH payments, disproportionate share payments, to be reported on a facility-specific basis and subject to audit.
Okay, these overpayments, were they an anomaly, or do you know what percentage they find or think are overpaid?
Well, what I can say is the very first DISH audits found that the majority of states, I believe it was 41, had overpaid at least one hospital. In one of our reports, we reported on the findings of the DISH audits, and 41 states had paid over 500 hospitals $2.7 billion on the non-DISH side, but they also reported on significant noncompliance on the DISH side.
Significant? Do you have any idea what percentage when you say significant, or?
So the DISH payments that were in excess of the hospital's uncompensated care and or not calculated with acceptable data and methods, 41 states exceeded the hospitals, made DISH payments that exceeded the hospital's uncompensated.
Yeah, but that didn't tell me what percent.
So 24% of the hospitals were found to have received DISH payments that were non-compliant.
24% across the board.
24% of hospitals.
Okay, thank you. And Dr. Schwartz, on Thursday, MACPAC commissioners recommended that the Secretary of HHS should collect and report hospital-specific data on all types of Medicaid payments for all hospitals that receive them. In addition, they said the Secretary should collect and report data on the sources of non-federal share necessary to determine net Medicaid payments at the provider level. As I have been told, HHS said legislation was necessary to implement reporting and auditing requirements for DSH payments, and that legislation would be needed to implement similar requirements for non-DSH supplemental payments. So why did MACPAC target its recommendations to the Secretary?
Sure. We have not asked for nor received a review from CMS of our recommendation. So I don't know what CMS will say about our specific recommendation. MACPAC's recommendation was for reporting of payment information, which we know from what is CMS is already asking of states in the UPL payment demonstrations that it is already asking for similar types of information. And that's why we believe that the Secretary had the authority to do this. Auditing is a different step, and auditing is a much more intense activity as seen in the DSH audits, and that's not what MACPAC was asking for. MACPAC was asking for collecting and reporting payment data, and so we believe that the Secretary has the authority to do that.
Okay, thank you. With that, I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Oregon, Dr. Schrader, 5 minutes for questions.
Thank you, Mr. Chairman. I guess for GAO, have you evaluated what the cost benefit might be in changing from reporting classes of overpayments versus going to the individual providers?
We have not evaluated the cost benefit, but we would note that this is required on the DSH side. So, and non-DSH payments are now higher in amounts than DSH payments, but the non-DSH payments are not subject to reporting and auditing as with DSH.
Has there been any consideration of just increasing the Medicaid payments as opposed to going with the DSH and non-DSH supplemental payments that we've got?
Well, ideally, Medicaid payments would be sufficient to ensure access in a local area comparable to what others outside of Medicaid would be receiving.
Like everyone in this committee and in Congress fully realizes Medicaid payments are not sufficient. As a matter of fact, they're so low that many providers can't accept Medicaid patients. We have the same problem with Medicare. I think a lot of folks need to be aware that that is a very, very low reimbursement rate compared to, the private insurance market.
Yes, our work has found that Medicaid payments are lower generally for certain services than private.
Has there been any move to just fund Medicaid to the various states and providers based on outcomes? There's been a lot of talk in healthcare recently about outcomes, quality-based healthcare.
What I can say is that I think that there are some demonstrations that are trying to incentivize outcomes by making payments for that.
MACPAC have any comments on that?
There's a lot of activity at the state level to try and link payment to outcomes through different approaches such as health homes, bundling of payments, different approaches. We don't know very much yet about the outcomes and whether they have affected outcomes. It's something we would be very interested to know. And it's also very difficult to conduct that research because you have to be able to control for everything else that's going on in the health system and in the patient's lives to be able to attribute the outcomes to specific actions on part of the beneficiary and the provider.
Well, that's interesting, and that's always true, whether it's an education bill or anything we do. But we are doing that right now in Medicare, trying to get at that in Medicare. We are doing that under the Affordable Care Act. So I don't think it's impossible, and certainly there could be risk-based reimbursement to accommodate the types of socioeconomic factors that people have. And I'd argue respectfully that rather than us try and micromanage all the states and the different providers, it'd be a heck of a lot easier for us, particularly non-doctors, although I guess I'm a veterinarian, but I wouldn't want to be the guy in charge of your health care, that, we go to an outcome-based reimbursement system where we could easily judge whether or not the people are staying healthier, staying out of the hospitals, getting that quality-based health care. That should really be what we're about. Then our task here would be pretty easy. We would just be able to have a common set of outcomes, and your job would be a little bit easier, and we could see whether or not things are doing well or not. Another question on the in the reports bill. Why do we have the 40-60 rule? Why is that significant? What's the goal of having that rule?
I can't speak to the legislative history around that rule, but I think that the concept generally is that states should share in the non-federal share of the financing.
But why do we specify it can't be more than 40 or more than 60? What's the point of that? Who cares? Why do we care? I'm the federal government. Well, if someone's paying their fair share, why do I care?
Well, I think that to make sure that the incentives are for efficient and economical payments, that the state should be sharing in the cost of the payment.
Yeah, but who cares if it comes from the local government or a private enterprise or the state? Who cares?
The concern around the reliance on providers and local governments for financing the non-federal share is when the burden on financing Medicaid rests with, for example, the providers who are serving the beneficiaries. From the provider standpoint, the payment they receive from Medicaid is the net payment. It's not the full payment. It's the payment less the taxes or other contributions that they might be making for the payment that they receive.
Mr. Chair, I just respectfully suggest we're micromanaging and should let the states do what they do best and just regulate the outcomes. I think that'd be a smarter proposal. And I yield back. Thank you, sir.
Chair, thanks, gentlemen. Now recognize the gentleman from Indiana, Dr. Bouchon. 5 minutes for questions.
Thank you, Mr. Chairman. I would agree with what you just said. I think we're micromanaging, and I can tell you why CMS wants to know the information, because they want to decrease payments to the Medicaid program. They want to save money. And I was a provider before I was a surgeon, and you can't have access if you continue to decrease Medicaid payments, because you have a program that needs fundamentally restructured, in my view. You can't have both. And so now states, including Indiana with Healthy Indiana Plan 2.0, which is a HSA-based way to manage the Medicaid population. Now what basically your testimony is telling me that, wow, you guys came up with a great system, but we don't want you to do it because we're concerned it's going to cost the federal government more money, and we're trying to save money here. So the question, I'm playing a little devil's advocate here. The question I have is, why does the federal government care? For example, Healthy Indiana Plan 2.0 uses hospital taxes to, as you probably know, to help fund the expanded state share of the expansion under the Affordable Care Act. Why does that matter to the federal government? Because what they're doing then is they're reimbursing providers at a higher level than traditional Medicaid. Guess what that does? Gets providers to take Medicaid patients so that we get access, so low-income people actually can see a doctor. So why does that matter to the federal government? Does that cost the federal government any more money than it would if they did it in a traditional way?
I think the most fundamental reason that the federal government pays is that when you look at the financing, federal, non-federal, the federal government is still paying on average 57% of the cost of the Medicaid program, and much more than that in many states.
So?
Notwithstanding how. So the
what?
interest is in ensuring that that amount of money is being used consistent with the aims of the statute.
Okay, so they want to micromanage the Medicaid program, just like Dr. Schrader said. The basic, what I'm getting is that the reason is because the federal government wants to micromanage the states. That's my view on that. I'm all for reporting, and I think states should be compliant with coverage and make sure people are getting adequately coverage. But other than that, the question I have is, why does it matter to the federal government? That's why I support fundamental Medicaid reform that gives the states a certain amount of money and let them do what they need to do with it versus having all these strings attached. And I mean, I think we're just finding today with this hearing why we need to fundamentally restructure the Medicaid program, because people are spending literally thousands of hours trying to figure all this stuff out. Like I said, I don't have a problem with needing to be reporting if it has an impact on patient access. I mean, if there is a concern that based on states using local or state funding for the non-federal portion is having an impact on access and people are not getting the services, that's one thing. If it's just because the federal government wants to say, well, look, we don't have to pay you as much because you found a way to use local money or state money to help yourself, then I'm against that. And so why does it matter if the state reports, for example, in the aggregate versus an individual provider? Why would the federal government care? It's the same amount of money.
Well, as you point out, you know, we want to make sure that Medicaid payments are going for Medicaid purposes and to improve access to Medicaid beneficiaries. Without knowing,
And I agree with that.
Without knowing the amount that an individual provider is contributing to the payment that they are receiving, we can't actually understand whether or not the payment is being used basically for fiscal relief for the state or actually serving to improve access for Medicaid
Okay,
beneficiaries.
that's fair enough, but what you just said is making the assumption that states are purposely violating federal law for their own benefit. If you make that, and that I'm just saying that CMS needs to know this because they want to prevent states from purposely violating the law by using Medicaid dollars for for example, giving payments to people who are not providing coverage to Medicaid patients.
And
is that true or not true?
It's not necessarily even violating the law. States can make payments and receive federal matching up to the upper payment limit. And there is no limit on Medicaid payments in relation to costs. This data is really needed to understand the extent that payments are going to providers who are actually financing the non-federal share, therefore reducing the net payments to the providers. Because
my time has expired, so again, I'll just finish by saying, who cares? Because it's the same cost to the federal government. Who cares? I yield back.
Chair thanks the gentleman, and now recognize the gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. I had a question I'm very interested in these demonstration projects to explore alternative venues or settings for long-term care and the financing of those. So I guess the most obvious example of experimenting with this is there are some waiver and demonstration programs that have allowed for Medicaid reimbursement for placement in, say, assisted living facilities as opposed to long-term, nursing care facilities. I don't know that there's been, but you would know, I imagine, demonstration projects that are reimbursing through Medicaid for placement in somebody's home where they're getting some home care. But my question is, as those kinds of alternatives are being explored, are there also alternative kind of financing structures or formulas being looked at the same time? So obviously you'd be looking at different kinds of reimbursement amounts depending on the setting. But is there any reason, for example, to look at some of these asset thresholds and other things depending on, my instinct would say no, but I'm just wondering, has that kind of analysis accompanied the experimenting of just where you might reimburse for this kind of care?
We have work planned to look at Medicaid payments for assisted living. We have not done work looking at financing of Medicaid payments necessarily directed to long-term care, if that's your question.
Mm-hmm. Okay, and are there, is it in your bailiwick to tell me whether there are demonstrations that are actually looking at Medicaid reimbursement for home care where somebody's actually staying in the home?
There are increasingly states moving from a fee-for-service type of payment for long-term care services to managed care, which would be, a capitated payment amount to cover all services, including long-term care.
So in that instance, there would be a capitated payment for providing care along a continuum that could include some component of home care along with institutional care? Is that what
Correct.
you're saying? Okay.
Correct.
All right, thank you. I yield.
I can just add to that about half of payments for long-term services supports in Medicaid are now occurring in a non-institutional setting. And this reflects a very big shift over the past 20 years when it was primarily in institutional settings. And that's primarily through 1915 C waivers that have allowed states to move, allow folks to stay in their own homes and receive services if that's something that's valuable to them. And there have also been grants under the Money Follows the Person program to help states transition people from nursing homes to home settings, or to allow people to stay in their homes and not end up in a nursing facility.
Thank you.
Chair, the gentleman yields back. Chair now recognizes the gentleman from Maryland, Mr. Bilirakis, 5 minutes for question.
Florida.
I mean, Florida.
That's
sorry.
okay. No problem. Well, I have a couple questions here, but I wanted to say how much with the moving the patient from a long-term care facility to the home, obviously quality of life is number one, but are we saving money at the same time?
Those waivers require a demonstration of savings. And so, yes, and in the managed long-term services and supports area, I think that's also an area to increase the predictability of the amount that's being spent on long-term services and support. So fiscal concerns are obviously a part of both of those efforts.
Very good, thank you. A couple more questions. Ms. Aratani and Ms. Swartz, in your testimony, you talk a lot about non-state sources being used to fund Medicaid. Can you explain what these non-state sources are, such as provider taxes, and how they fund state Medicaid programs?
States are allowed to use up to certain sources of funds apart from state general revenues to finance Medicaid. Provider taxes are an increasing method that states use to fund Medicaid, which would be a broad-based uniform tax on healthcare providers that, and it could be Medicaid providers to fund Medicaid. Intergovernmental transfers and certified public expenditures are other methods that are increasingly used to finance the non-federal share of Medicaid. These would be methods that local governments or local government providers, such as county hospitals, might use to, for example, in the case of certified public expenditures, to certify that they had expended a certain amount on Medicaid for purposes of getting federal matching for the payment or the fund.
Do you have anything else to add,
No,
please?
I don't have anything else to add to that.
All right. Okay, federal law requires that provider taxes must be broad-based and uniformly imposed, and must not hold providers harmless, and cannot provide a direct or indirect guarantee those providers will receive all or part of the tax payment back. How does the use of non-state funding sources such as provider taxes reconcile with federal law?
It's permissible under federal law, and changes have been made over time to clarify the circumstances under which it's possible, and the ones that you just named are examples of that. But it is a permissible activity. There's no intimation that something shady is going on with these taxes, and they're clearly important in many states as a source of funds to support the Medicaid program.
Okay, next question, Ms. Aratani. In 2014, you asked CMS to ensure states report accurate and complete information on all sources of funds used to finance the non-federal share of Medicaid. What data did you want to capture, and what was CMS's response to your recommendations?
Yes, we suggested that CMS come up with a data strategy for obtaining complete and reliable information on sources of funds. Currently, CMS does not collect specific sources of funding. CMS agreed that they needed better data for oversight purposes, but disagreed with our suggestion that they needed this data at the provider level for, in particular, institutional providers. We felt like the data is needed at the institutional level so that a net payment to the provider could be understood. For example, if a hospital is getting $200 million from CMS in a supplemental payment, that CMS would also know that that provider was being asked to finance the non-federal share, $100 million or more, whatever the non-federal share of the payment would be. This is important not only for understanding the trends in financing and the net impact on the provider, and whether it'd be helpful to understand the extent the payments are actually going to improve access to the beneficiaries as opposed to cost shifting to the federal government or providing fiscal relief to the states.
So one final question, if I may, Mr. Chairman.
May proceed.
Okay, thank you. Ms. Aratani, Medicaid is listed by GAO as a high-risk program. Can you explain why this program is listed as high risk?
Yes, there are multiple contributing reasons based on our body of work over the last years, but Medicaid is a significant program in terms of size, in terms of the number of enrollees, now the largest health care program in the country. It's a diverse program. The federal state nature of it makes it very difficult for oversight. Our work has identified concerns with gaps in oversight, including the transparency of supplemental payments and many other types of issues that contributed to our putting Medicaid on our high-risk list.
All right. Thank you. Thank you very much. I yield back, Mr.
Chair,
Chairman.
thanks, gentlemen. I recognize the gentleman from New York, Mr. Collins, 5 minutes for questions.
Thank you, Mr. Chairman, and I want to thank our panel for being here. I think examining Medicaid programs are very important, and we've kind of been doing it in many ways today. I guess I'd like to start by standing with Dr. Bouchon and saying if we could block grant Medicaid back to the states, I don't even think there would be a need for today's hearing. But unfortunately, we haven't done that, so that's one of the reasons we're having this hearing, which I think is timely. And maybe to respond a little bit to Mr. Guthrie's comments earlier, Medicaid's all over the place when it comes to how states administer them. And, maybe to sum up a little bit, I'm from New York, which New York, with 20 million Americans, spends as much on Medicaid as California and Texas combined, with 60 million people. That shows you how crazy this program is. 36 or so states, as I understand it, absorb the Medicaid cost at the state level, and there is no local share. It's about 36 out of 50. Well, the 14 states, of which New York certainly one, push this back to the county level. In the case of Erie County, where I'm from, Buffalo, I was the county executive, and 100% of our property tax did not even cover our Medicaid share at the county level. 100+% of our county tax covered Medicaid, which meant the county had to live on sales tax. Well, when it gets to DISH, it's worse. In New York State, when the federal government makes a DISH payment, the state pays nothing. They force 100% of the match for DISH payments down to the local level, to the county. Erie County Medical Center. We're talking about $40 million in a year. Now, under the ACA, to speak to the folks on the other side, the DISH payments were supposed to be reduced dramatically by the expansion of Medicaid and affordable care. Well, it hadn't happened. As I understand it now, just maybe we'll see a DISH reduction in 2018. But that may go the same way as SGR and just get kicked down the road. And I just bring this up to put into context how Medicaid's all over the place through the country. And if you're living in Erie County, New York, it doesn't get much worse when it comes to what we're having to bear for that burden. So briefly, the bill that I've put forth, H.R. 2151, really addresses the non-DISH supplemental payments. And this came from the GAO's own report on we need transparency. You know, I have a sign in my office, and God we trust, all others bring data. We don't have the data on the non-DISH supplemental payments. And so, Ms. Iritani, I'm assuming the bill that I'm putting forth on simply asking states, or not asking, requiring states to do audits and CMS to do audits on non-DISH supplemental payments is something GAO would certainly support.
Yes, we would agree that that bill is consistent with our recommendations.
And really, in learning from that, I think all of us would support payments going where they're supposed to, but do you also have any data on the 50 states? I understand it's very inconsistent from state to state. And crazy thing I've heard is I don't think New York does as much non-DISH supplemental. Is that true? Do you know?
I cannot speak to that right now, but be happy to
Yeah,
work
if
with
you
your
could get back to
secretary
us,
on
and it'd be interesting just to see as a percentage or absolute or both on the non-DISH supplemental payments, and then that would also beg the questions and I think we would see wide variances
There
from
are-
one state to the other, and it would beg the question, why is one state doing one thing and another doing something else? But without the audits, how do we know? And
There
I
are
think
great
that-
variations among states and how they finance our programs and the extent of supplemental payments.
And just from a common sense standpoint, that doesn't make any sense to me. So, you know, I would certainly urge all my colleagues to support that bill, H.R. 2151, which is simply trying to gather data in a way that would help us all better understand, state by state even, what's going on. So, again, Mr. Chairman, thank you for holding this hearing, and I yield back the balance of my time.
Chair, thanks the gentleman. Ms. Schwartz, did you want to add anything?
Well, I have some data here that show that nationally supplemental payments as a share of inpatient and outpatient hospital payment is about 44%, and in New York it's 36.8%, so it's below the national average. But the figures go all over the place from 2%. There's several states in the 80s and one or two in the 90s. So you're slightly below the average, but like all things Medicaid, it varies by state.
And I think, again, we could use some data to understand why that variation would be what it is. Thank you very much.
Yeah, Chair, thanks the gentleman, and now recognize Mr. Griffith for 5 minutes.
Thank you very much, Mr. Chairman. As we have discussed in some of the prior testimony, a state may impose a broad-based health care tax on providers and use the revenue raised from that tax to pay for the Medicaid program. Virginia looked at that a couple of decades ago, and it was rejected because it was considered a sick tax or a bed tax. And why would we want to put more burden on those people who are already sick by having a broad-based tax on folks who are in the hospital? But because of the way the FMAP works, the Federal Medicaid Assistance Percentage, the effect of this is that a state can draw down more and more federal spending in its Medicaid program. Currently, these provider taxes are permissible, as we talked about earlier, if they are applied at a rate that produces revenues less than or equal to 6% of the provider's net patient revenues. Now, I know, Ms. Schwartz, you said that's not cheating, but from a Virginia perspective, even though it's legal, it's seen as a little bit dicey that you get more money because you charge your sick people more taxes, therefore you can get more money drawn down from the federal government. Can you talk about any work that either MACPAC or GAO has done to explore provider taxes to see how they're utilized by the states and how they drive up the spending, or how provider taxes can create what we believe in Virginia is a perverse incentive in Medicaid? Either of y'all want to tackle that one?
We've written about provider taxes and described the statute as you have, and we have expressed, there's been an expression of interest in learning more, but it's a topic that's difficult to study because you're having to look at the finances of the entire state and their tax structure. So it's not one that we have a lot to offer now, but I'm hopeful that in the future we'll have more information to be able to share on that.
Well, as Mr. Bouchon said earlier, maybe we'd be better off if we just decided what was the right amount for each state and sent it back to them, and then you don't have all these little games being played about we're going to charge our people a sick tax so that we can then draw down more money. I've introduced a bill, the Medicaid Tax Fairness Act, which is co-sponsored by some of my colleagues on the committee, Blackburn, Bouchon, and Guthrie. That doesn't get to the whole problem, but it does reduce the current provider tax threshold from 6% to 5.5%, which is what it was just a few years ago. What do you all think of that concept? And there's a follow-up question, too.
We have looked at states' uses of provider taxes at a broad level, at a national level, and have found that states are increasingly relying on provider taxes as a source of the non-federal share of Medicaid. And we looked in 3 states at arrangements where indeed there was an increase in the Medicaid payments and some sort of contribution, for example, through provider taxes from the same providers that were receiving payments. And so we would agree that there needs to be much more transparency on what is reported. And with regard to your proposal about reducing the provider tax, that I would just note that there have been several bodies, including CMS in its budget, that have also suggested reducing provider taxes as a way to improve the fiscal integrity of Medicaid.
Yeah, and my bill is actually the first step, I think, but it's H.R. 1400, and then we can go forward from there. And what's interesting is folks on the other side of the aisle will recognize oftentimes I'm in conflict with the administration, but in December 2010, President Obama's Fiscal Commission said Congress and the President should eliminate state gaming of Medicaid tax gimmick. They recommended restricting and eventually eliminating this practice. While this policy would obviously need to be phased in incrementally, does GAO or MACPAC, and I think you've already answered it in part, but do either of you have a position on that policy? And if not, can you comment on benefits of reducing the use of the provider taxes over time? And you may have already answered it in your previous answer, and I recognize that, but did want to get it out there that it's this is a bipartisan thought. It's not something that we own just on the Republican side or just on the Democrat side, but gaming the system moves money around, but it doesn't really help the sick folks. Comments? Agree, disagree?
I would just say that from the Commission's perspective, that the interest at the moment has been on transparency, and that's you need those data to be able to then evaluate different policy options. The Commission, as of this time, has no position on that.
And I would just say at some point, and I haven't introduced a bill, and maybe I should, but at some point we need to look at helping folks out. I had a little concept when I was in the state legislature in Virginia that would allow folks who needed medical care, maybe not as intense as a nursing home, but needed at least 2 things a day that were of assistance, and we passed a law that would allow, North Carolina has a similar law that would allow a medical cottage to be placed, a temporary, to be placed in a family member's backyard, side yard, whatever, worked under the regular laws, but it created a zoning exemption for that. It might be a way that we can save money for folks all the way around because it's cheaper than a nursing home, but the person's still getting care and they're with their family. It's a good win. We ought to talk about that later. I appreciate it, Mr. Chairman. Appreciate the time, and yield back.
Chair, thanks to gentlemen. That concludes the questions of the members present. As usual, members who are in other hearings on our committee may have questions. We'll submit those to you in writing along with any follow-up questions. We ask that you please respond promptly, and I remind members that they have 10 business days to submit questions for the record. So members should submit their questions by the close of business on Tuesday, November 17th. Very interesting hearing, examining various Medicaid programs, a very complex issue. Thank you very much for your time and testimony today. Without objection, subcommittee is adjourned.